Hi, everyone. Welcome to our webinar. We are going to just give it another minute or two for some last minute joiners, and then we'll get started. All right, well, let's go ahead and get started. My name is Elise Roederer. I'm the director of the Governor STEM Scholars Program. I'm so thrilled that we're able to do this in conjunction with the Research and Development Council of New Jersey and the STEM Pathways Network. I am thrilled to introduce our two speakers today from the New Jersey Department of Health. First, we have Thalia Sergiu, who's the Deputy Chief of Staff for the Department of Health, and Greta Anschutz, who's the director of STD services. Sorry about that, ladies. So excited to have them. While those are their typical day jobs, over the last few months, they've really transitioned and are leading the COVID contact tracing efforts and are now really being pulled into vaccine distribution. So we can learn a lot from them about contact tracing, vaccines, and COVID-19 and how the state is responding. So thank you so much, ladies. I'll turn it over to you.
Greta, you want to jump in?
Yeah. Sorry, just checking, making sure I was off of mute. So again, hello everybody. My name is Greta Anschutz. Elise did ask us to share a little bit about where how we got to where we are. So I am the first generation of my family to go to college. I went in thinking I really liked chemistry and organic chemistry and biology, and so obviously I should be a pre-med major. Went through my whole undergrad basically being a pre-med major, didn't get into medical school, and said, well, there's this thing called public health. I don't know a lot about it, but I have a friend who's in public health, and she said I should look into it. The first class I ever had to take was about epidemiology and outbreaks and trying to figure out what caused everybody to be sick. And I knew right then and there that med school was not what I wanted to do, and public health was it. And I have now been working in public health for over 15 years, mostly around sexually transmitted diseases or STD. So I'm very glad to be here, but before I get started, I wanted to give Thalia a little bit of a chance to tell her story.
Thank you, gracious Greta. Hey everybody, Thalia Sergiu. Like Greta, I accidentally fell into public health from an initial desire to go to med school and become an MD. But very soon after I dipped my toe into the public health realm, realized that this is what I wanted to do the whole time, and I just didn't know that such a field existed. So really excited to be here. I worked after going to college, undergrad, I worked for about 8-9 years before deciding to go back to grad school for my master's in public health, which I'm still finishing. Finished all of my coursework and am now still trying to get my thesis done, but you know, COVID, so still have to finish that. But it's been a whirlwind of learning as you go along and applying the skills that you might not realize are very critical, important skills about critical thinking and flexibility and adaptability. But Greta and I have learned very quickly that we have to rely on our knowledge of thing one to figure out how to do thing two. So we're excited to be here, and we're going to tell you a little bit more about our non-day jobs in the COVID world. So turning it back over to you, Greta.
Awesome. So next slide. There we go. So Thalia and I wanted to give a little bit of a disclaimer, and it's not our traditional disclaimer that we normally have to give, but what we wanted to remind everybody is that COVID has really taught us what it's like to live in the middle of a science experiment. There's new hypotheses coming out every day that get tested that end up either being right or being wrong. So we just wanted to give a little disclaimer that the information presented today is as we know it of today. And if it changes tomorrow, that's what it's like to live in a science experiment and go with the flow. So next slide. So after today, we want to be able for you guys to describe the history of case investigation, what epidemiologist is, what's the process that we're using to figure out if it's an outbreak, how we want to break transmission, some of the newfangled technology that COVID has brought to the forefront, including exposure notification and Bluetooth technology. And then we're going to go into a little bit about how vaccines work and what's the whole big deal about an mRNA vaccine and why it is kind of new and exciting, and the times that we are living in, every day we learn something new. Next slide. So we wanted to start off with a poll question. And our first poll question is to take a guess. When do you think people started using what we call contact tracing, which is taking a known case, asking them where they've been, who they've been around, and then letting those people know that they may have been exposed to a disease. So options are the 14th and 15th century with the infamous bubonic plague, where the rats were infesting everywhere in Europe, and there was a lot of death, and that was probably one of the earliest recorded pandemics that I'm aware of. In the 1700s with smallpox. In the 1930s, following the discovery of penicillin, at which point antibiotics could cure a lot, or our favorite in the 1990s when the internet made everything possible. All right, do we know if the poll got launched? Or I don't think that one was part of the poll.
I don't think that one was part of the poll.
Ah, okay. So I see we have first with the 1700s, which that is when you look at when they probably called it contact tracing, the 1700s is into the right area. But if we go to the next slide. It actually has been dated all the way back into the bubonic plague, into the 14th and 15th century. And so if everybody here has kind of heard or thought about little things like quarantine and isolation, so if you're sick, you have to stay home and stay away from people, and if you've been exposed to somebody who's sick, you have to stay home and stay away from people for 14 days. The quarantine actually dates back to when in the port of Venice in Italy, all of the ships had to stay out to sea for 40 days before coming in to make sure that disease wasn't spread. So if you could imagine being stuck on a ship for 40 days, even just having enough food and supplies to get through, while the 14 days we are enduring now is not for fun, 40 days, I'll take the 14 any day. Next slide. So when we've been throwing around a lot of words, one of the big ones that we always get is epidemiology. I can tell you that my parents had no idea what this was. My father carried around a business card of mine with the definition of epidemiology on the back so he could explain to people what his daughter did. So a lot of people think it has to do with your skin because the first thing they think about is epidermis. So in terms of epi, thinking about what things are happening, demo is people, demographics, and always our ologies are the study of. So with epidemiology, we're literally talking about what befalls on people, what affects people. So Thalia and I are more concerned about health, looking at things like infectious diseases, chronic diseases, heart disease, cancer, infectious disease. Sometimes we're looking at things like salmonella and food outbreaks. But ultimately what we're trying to describe is the items that affect humans and how it affects them. What's the age? What's the gender? Who lives? Who dies? Did they go to school? Did they eat the rolls and the butter? What caused the disease? And so epidemiology really is that study of trying to figure out what befalls people. Next slide. So when we talk about the pioneer of epidemiology, his name is actually John Snow, but if you want to go to the next slide, it is not the John Snow we all know and love, but it's this man. So he had one of the most famous outbreaks in studies that go on that any epidemiologist, any public healther has heard of John Snow and knows this outbreak. So cholera is actually a disease that comes out of the water in the wells, and people would drink the bad water, they would get sick, and they would die ultimately. And John Snow wanted to figure out what caused this. And while we know today that it was water in wells, that wasn't commonly known. And what he did in the 1700s was actually map out where all of the cases were living, which is one of the key tools that we use in epidemiology, where we go through and try to say, well, where do all the cases live and are there any commonalities? So we're going to talk a little bit more about what he found, but if we want to go to the next slide, I get to have a break and water and we get a little video. Valerie, I'm not hearing any sound.
Hold on, let me try that again.
Everyone from the public to the medical establishment accepted it. But by the 1840s, in the midst of devastating cholera outbreaks in London, a small group of scientists had grown skeptical. Early microscopes had revealed the existence of tiny microorganisms, and they proposed that it was actually these germs that caused diseases, hence the name germ theory. Though most people held on to their assumptions and strongly resisted this theory, its supporters were determined to prove them wrong by collecting compelling data. Leading the charge was a physician named Dr. John Snow. Dr. Snow observed that cholera-infected patients experienced severe vomiting and diarrhea, symptoms of the gut as opposed to the lungs, and thought that perhaps the disease was transmitted through food or drink, not the air. After investigating previous outbreaks, he became convinced that
Oh, did it stop on your end?
Yeah, it looks like it's buffering, but I don't.
Oh, sorry about that. I don't know what's going on.
Internet.
All right, well, I'm going to jump to the next one.
Think so. Unfortunately, we get the cool story.
Okay.
So before we jump in, I will tell you what the cool story was supposed to tell you. So John Snow basically started seeing that all of these people had something that seemed to do with their respiratory. He started mapping out where the cases lived, and it didn't make sense, right? Because a lot of the cases didn't live in the neighborhood But coming to find out as he investigated and called the cases and talked to them, or knocked on their door because it's before telephones, he was able to find that like some people all used the same water well. And for some of them, it was they worked near this well, they went to school near the well. One person was reported as saying that they liked that taste of that water better than the others. And so he was able to convince that they should maybe shut this well down because it probably was the bad well. And what they actually found, because again, it was the old times, that there had been an initial case who had cholera, passed away from cholera, and the waste receptacle was right near the fresh water. And so the thought is that the cholera from a dirty diaper ended up in their water supply because, it was 1700s. We're not that great at public health measures of keeping clean water clean. And so what ended up happening was that they took the well handle off, and when they closed that well, no other cases continued to happen. So it really became and showed that how important investigations are for those that have a condition like COVID or cholera are to understanding what goes on. Within epidemiology, we have 3 items that we're always looking at. The host, which is the human being who carries the disease or who exhibits symptoms of the disease. You have the agent or a microbe of what is actually the disease itself. So, you could think of the host, it's us humans, the agent, it's COVID. And then you have the environment. So where is the disease spreading? So, I think we've seen a lot, like our diseases are spreading from our everyday living, whether it's going to a house party, whether it's going to a school dance. Any of these items that we used to know and love actually are what's helping the disease spread. So with John Snow, he came in and he was able to identify basically the environment for where the disease was at. And once he closed down the water pump, then there was no more transmission of disease that was linked to that water pump. So whenever we're looking at something that causes disease, causes people to be sick, we are trying to figure out who does it infect, what is the microbe or what is the bacterial that's causing this, and then where is it happening, and which one of those can we change so that we can make sure we can go back to our normal days of living. Next slide. So I got involved with COVID contact tracing because my team on a regular basis does contact tracing for sexually transmitted diseases. You guys might have heard of chlamydia, gonorrhea, maybe syphilis, probably I hope HIV, but all of these diseases come to the Department of Health as case reports. And what we really want to do is make sure that we can find other people who may have been exposed to those diseases and let them know that, hey, you might want to get tested, you might want to get treated, because if we're able to test and treat the partners, then we can stop disease transmission. Even for HIV today, I always have to get my plug in. We have new treatments that can prevent people from testing positive. So it's always important to be talking to your doctors about what's right, but also making sure with the health department, taking the call for the education so that you can make sure you keep yourself healthy every day. One of the challenges that modern contact tracing has is that, we move around a lot easier than we used to in the past. So it is very easy to travel throughout the whole world. And I think we saw that too with COVID as how fast it traveled. But we also have technology now. And while we're going to tell you a little bit later about how some of the technology has been used for the good on contact tracing, it also does have some negative impacts at times. So a lot of apps out there help you meet people a lot quicker. Whether you know them as have heard of all of the dating apps that exist, there are lots of them, but it allows people to not always know who they've been around. So in terms of a person diagnosed with an STD called syphilis, on average, studies have found that people have 10 partners or 10 sexual contacts, but they only know 2 of them in order to find them. So one of the top trials we really have within contact tracing is knowing who you were around and who might have been exposed to whatever condition might be out there. Next slide. So with contact tracing and COVID, we basically have 4 things that we've been trying to do. The first we really start with is getting everybody to test so they know their status. Once they test, we want to make sure that we notify cases, i.e. those who test positive, and say, you know what, you need to stay home or you need to isolate so that we are able to stop transmission. If you feel like you can't stay home, you need to seek treatment as soon as possible. While we're telling people to stay home and isolate away from everybody, we're also asking them about who they may have been in contact with so that we can notify those individuals and see if they're already feeling symptoms, and if they're not, making sure that they stay home in quarantine. During quarantine for 14 days, we want to monitor the people who've been exposed so that if they end up developing any symptoms, then they become cases and we start the process all over again. So lots of public health words here, but people who have disease, stay home, tell us who they've been exposed to. We tell those individuals to stay home. And our hope here is that if we all work together and do our part, that we would be able to stop transmission and go forward. Next slide. So a lot of people are nervous when the health department calls them. We've had a lot of scammers, a lot of people who don't believe us. People try to impersonate us. But during a COVID contact tracing call, a lot of times what we're going to first do is confirm who you are. We might ask you what your date of birth is to confirm it so we make sure we're talking to the right person. We might ask you what your address is, or if you already have a positive lab result, we might ask you where did you see the doctor on January 25th, because then we would be able to know we're talking to the right person. We're going to ask you how you're feeling. You know, do you have any cough, fever, any runny nose? We're going to talk to you about staying home for 10 days and away from anyone in your household in order to isolate so to not spread disease. We understand that that also could be a real hardship. So we're going to talk to you about if there's any social support needs. You know, do you have a way to get groceries? Do you have a friend who can bring them and drop them on your doorstep? And then we're going to talk to you about who you might have exposed so that we can notify those. For contact tracing, it's always done confidentially. So I'm not going to call Thalia and say, listen, Thalia, when you were hanging out with Joe, he gave you COVID. You got to stay home now. It is never that specific. What I'm going to do is say, Thalia, you have come into close contact with somebody who has been diagnosed with COVID. I cannot tell you who that is, and I cannot tell you anything about where you might have been, but I need you to stay home. So you can guess a lot of people don't always believe us, but it is important that they take the advice and do stay home to stop the spread of disease. We're going to ask about their symptoms. Again, any fever, headache, cough, and then we're also going to identify their social support needs to say, you know, do you have enough food for the next 14 days? Do you have enough medicine? A lot of times we forget about medicine. Some of the information we'd have is, you know, people have young children at home and they don't have enough diapers for the next 14 days. So those are all the types of items that we try to help with to make sure that they're able to safely stay home. Next slide. So one of the other real big items within epidemiology and disease investigation is looking at what we call an incubation period. And this basically tells us from when you were exposed to when your first symptoms become apparent. And when you've been exposed to your first symptoms, once you're symptomatic is usually when you can be spreading disease. So the day you get exposed, you aren't going to test positive. You're most likely not going to be infecting other people. It's once the virus is in your body that it starts to replicate, which then at that point shows symptoms like the runny nose, the fever. That's when you're most infectious. So when there's a long incubation period, contact tracing works much better. So we talked earlier about syphilis. On average, the incubation period is 21 days. So 21 days from when I've been exposed is when I start potentially infecting other people. For COVID, we've been really challenged with contact tracing because we only have an average of 5 days. And it's a range, minimum 2 to 14 days. So it really is a challenge for us to find out that somebody has been diagnosed with COVID. They got tested. The test was run by the laboratory. The laboratory reported it to the local health department, and we call a person on the phone. That right there can take days to occur, and that's really a huge challenge on trying to contain COVID. Next slide. All right, so after we've had a lot of discussion here, we did want to throw up a poll question. So when we talked about contact tracing and calling people and asking them what do, who you've been around, can you stay home for 14 days? Are there any type of support services that you need? What item do you think is the most important to make that phone call successful and that the person on the other end believes us? Right. I think we got two very, very good answers here. There is no right answer, honestly. The trust is very important, and making sure that everyone understands that their local health department is not going to sell their information, is not going to, abuse their information in any way, but also very much so people who answer their phones. Very critical that when you get an unknown number, picking up that unknown number, which I can confess I'm horrific at doing as well. But it is important to make sure that you get notified as soon as possible. Next slide. All right, Thalia, I'm going to switch it over to you for a different tone of voice.
Thank you, ma'am. So I am going to talk to you all a little bit about our exposure notification app, COVID Alert New Jersey. So we're going to start off with a quick video from Google, just explaining, giving a little bit more background about what the exposure notification technology is and how it works. Okay.
Battling COVID-19 is an unprecedented global challenge. To get communities around the world back up and running as quickly and safely as possible, public health authorities are building smartphone apps to help with contact tracing. Contact tracing is one of the best ways to stop a virus from spreading. It can take thousands of disease investigators to alert everyone who's been in contact with people who've tested positive. But even if disease investigators do their jobs perfectly, alerting the people a COVID patient doesn't know or can't remember is incredibly difficult. Smartphone apps that public health authorities build can help people at risk of infection get notified much more quickly. But a contact tracing app works best when more people download it. And being asked to download an app without knowing how it will handle your personal information might cause people to worry about their privacy, and they may not feel safe participating. That's why engineers at Apple and Google have been working together to make public health technology that protects individual privacy so that people never have to choose between their privacy and the health and safety of their community. You're probably wondering what that means and how that all works, and we're going to walk you through it in a second, but first let's be really clear about a couple things. First, apps using this system cannot track your location. And second, this system does not share your identity with Google, Apple, or other users. Here's how that works. For every phone that's opted in, our technology disguises your identity by generating a random sequence of numbers that change every few minutes. Then, using Bluetooth, anytime your phone detects another phone close by that's also opted in, the two exchange those random numbers. If in the future someone's positive for COVID-19, they can report that positive result in their app. Any phones that had exchanged random numbers in the last 14 days will receive a notification that they may have been exposed to COVID-19 without revealing their identity. Public health authorities can then help anyone at risk get testing and treatment. But it's up to all of us to help with contact tracing. Do your part and look for your public health authority app that uses this exposure notifications system. The more people who participate, the sooner we can beat COVID-19 and get our communities back on their feet.
All right, so just to share a little bit about how the app works in concert with what we call traditional contact tracing, which is what Greta was just describing to us. So with traditional contact tracing, obviously we do our case interviews and the contact notifications, and you have actual folks calling people to talk to them about their experiences, their locations, where they could have, where and who they could have potentially exposed. And it requires a pretty deep sense of trust, as we discussed a little while ago. Also, I think one of the most critical things here is it is very reliant on folks remembering where they've been and who they've been around, and knowing exactly what it is, who that they might have potentially exposed. It also requires, as Greta said, a pretty sizable workforce, small army of contact tracers. In the last, 8 months, we've hired close to 3,000, like 2,500 contact tracers, I think, to help with this just in the state of New Jersey. And our neighboring states in New York and Pennsylvania have also hired small armies, as well as states across the country. So it does take a lot of effort and training and people to do traditional contact tracing. So where COVID Alert NJ falls in is sort of supplementing that, definitely not replacing it. It's obviously a little bit lower touch. It kind of brings people into the fold to do their part. It's easier to scale, and you get some better analytics. And I think one of the most critical pieces that adds on to traditional contact tracing is the instances where you might not know the individuals who you've been around or exposed. As you know, we've kind of opened society back up a little bit. People are still out and about. People are riding the bus, riding the train, going to the grocery store, going to coffee shops. You may not necessarily know who you've been within 6 feet of for a little bit of time, depending on what your experience has been. So even if a traditional contact tracer were to call you, you're not going to say, oh, and also that guy on the bus that was riding the bus with me. Like, you have to figure out who he is and call and let him know. That's where the app comes in, because if both you and your fellow passenger on the bus or the train or at Starbucks or whatever have the app, you can put into the app, hey, I've had a positive test result, and the app will give that individual an anonymous notification and let them know that they should take some precautions to protect themselves. So let's talk a little bit more about the background, some background on the app. So as you heard in the video, Apple and Google unprecedentedly came together, put the guard down and worked together to do something, and that was to develop this exposure notification technology that our app is built on. It uses something called Bluetooth Low Energy technology. So it works in the background with just your Bluetooth, and that means it does not collect or use or track any location and doesn't share any of that information. The connections and those randomized codes that the video shared, they're only stored on your phone. And so they're not shared with anyone, not with Apple, not with Google, or not with any of us at the New Jersey Department of Health. And so it's a really important way for folks to be able to protect themselves and others around them in their community in the event that they are exposed. So the app is free, it's secure, and as we said, it anonymously alerts users if they have been in close contact with somebody. And I'm sure you've all had beat into you ad nauseum close contact means being within 6 feet of somebody for 15 minutes cumulatively, so throughout the span of a day. So you can spend 5 minutes here, 3 minutes there, and some other time later. And if it all equates to 15 minutes within a day, that is a close contact for you. The app is pretty important, not just because of that exposure alert notification, but it also has a way for you to track any symptoms that you may have, and also monitor information and statistics related to the COVID-19 epidemic in New Jersey. So again, I always like to reiterate, it never, ever, ever uses, tracks, or collects any geolocation or GPS data. That's the #1 concern that we get from folks, because obviously nobody wants to be tracked everywhere that they go. The other concern is about anonymity. Like Greta said, with traditional contact tracing, the contact tracer does not ever share the information of who the individual is that tested positive and potentially exposed you. It's the same with the COVID Alert NJ app. The random codes are exchanged between phones, and they're not associated specifically with a person, and they change every 10 to 20 minutes to preserve that anonymity. Right now, the phone is interoperable with 8 states: California, Delaware, New York, North Carolina, North Dakota, Pennsylvania, Wyoming, and Virginia. And there are a few more states that are currently building their apps on that same APHL, Apple, Google technology. Any other state that comes aboard, as long as they're building their app on the Apple, Google technology or activating what Apple is calling EN Express, then our phones will be interoperable. So hopefully soon, when we're able to move about the world and nation more freely, we'll be able to still have this as a tool to protect ourselves, our families, and our communities. So currently the app is available in English and Spanish, but we are working on a second version that adds 10 additional languages, including Portuguese, Gujarati, Russian, missing a whole bunch, Haitian Creole. There's a number of them that are going to be available in the next version that we're really excited about. So we'll talk a little bit more about how the app works. So once you download it, you leave it, you make sure that you do the setup, you opt in to receive exposure notifications, and as you go about your day, it just uses that Bluetooth low energy technology to match those codes with anybody that's with your close contact. So when the app senses that, it does the exchanges that random code and just stores it on your phone for the 14-day period. So once 14 days has passed, it deletes the old information to make space for new information. If you're to test positive, when you talk to a contact tracer, they'll ask you to enter a random code, kind of like how when you have to do 2-factor authentication, like if you need to log into something and it sends you a text, you'll get that code, you punch it into the app, and then you're able to upload all of your close contacts so that they'll receive a notification. So some of the limitations and considerations. So Bluetooth is a wireless technology, and while it works great, it sometimes is a little strange within a closed metal environment. So there are some concerns and tweaks with the technology as it's so new, and Apple and Google are still sort of working out the kinks in the technology. One of the other limitations, obviously, is it doesn't know if you're indoors or outdoors because it's not tracking location. It doesn't show if you were wearing a mask or anything like that. And it doesn't know if the devices, if you put your phone on the table with your friend's device and then you guys walk away, it doesn't know that because it's entirely reliant on the Bluetooth connection from your cell phones. And also public trust in technology. Trust in any and everything is at an all-time low these days, unfortunately, due to all of the misinformation out there. So it's a little tricky sometimes to get folks to really believe that the app is really a tool to help them and not, track them all over the place, especially when it's something developed by a government entity. So just a quick quiz to make sure everybody was paying attention. So what the COVID Alert NJ app, A, knows that you went to Wegmans. B, knows who I sat next to on the train. C, tells people that I am the one who tested positive. Or D, none of the above. Okay, so most of you got that right. The answer was D, none of the above. As we stated, the app doesn't know where you went, who you sat next to, not by name or anything, just that you sat next to somebody else with the app. And it will never, ever, ever tell anybody that you are the individual who tested positive. So next, we're going to jump into some discussion about vaccines. So Greta, do you want to jump in here and tag me in when you need me?
Definitely. I can start us off. You want to go to the next slide? So we have a little video about how vaccines work, and I'm hoping everything will work well here, but I'll go ahead and get us started on the video.
Aren't you glad you don't have scurvy? In 1747, in the first medical trial ever performed, Scottish physician James Lind found out that eating citrus fruits
Oh, come on.
could cure scurvy. Now, today we know this works because citrus contains high levels of vitamin C. In fact, ascorbic acid, a common name for vitamin C, comes from the Latin for not scurvy. By issuing rations of lemon juice to sailors, the British Navy was able to pretty much eliminate the disease until the late 1800s, when polar explorers suddenly began to see scurvy again. The copper pots holding their lime juice had destroyed the vitamin C, but they were pretty confused. So despite James Lind's experiments 150 years before, citrus fruits became the enemy. And when Robert Falcon Scott set out to reach the South Pole in 1911, he carried the finest in canned meat products, biscuits, chocolate, tea, and zero vitamin C. A Norwegian team beat them to the pole by 5 weeks, and during their sad journey home, Scott and his team perished in a blizzard, sick and weak from what was probably scurvy. It had been so long since anyone had seen this disease, the British had forgotten how to prevent it. When we create such effective solutions, we can forget how serious the problems were. Thankfully, people today don't die of scurvy or polio. Since the introduction of Jonas Salk's polio vaccine in 1955, the disease has been nearly eradicated from the earth.
The thing to remember is that this is a continuous process.
Compare the 358 infections reported in 2014 to the 1940s, when 500,000 people per year were paralyzed or died from polio infections. Vaccines work. Our immune system is on constant alert against germy baddies, with millions of white blood cells, each on the lookout for specific infections. When an immune cell meets its target, it replicates itself, and this clone army sends a barrage of protein weapons called antibodies to label the trash for cleanup. And after the infection is gone, so-called memory cells stick around, ready to mount a fast attack in case this germ shows up again. This is how we develop immunity, and it works pretty well, since we're all still alive. But even with all that, some super bad germs can take us out before our immune sentries have had time to call up their clone army. This is especially true for young children. Their immune systems are fresh out of basic training. Thankfully, we have vaccines, which are made of tiny pieces or weakened versions of viruses or bacteria. They let our immune system see what the bad guys look like and recruit those all-important memory cells before we ever have to actually see the real enemy. Thanks to vaccines, the US was able to eliminate measles in the year 2000. But in recent years, as more and more parents are refusing to vaccinate their children or are vaccinating them later than what doctors recommend, it's back. In most states, more than 90% of children are vaccinated, but that's not enough to keep a disease like measles at bay. In our episode about Ebola, we talked about a number called R0, the basic reproduction number for a disease, or the number of people infected by one person in a susceptible population. For Ebola, that number is low, But for measles, each sick person will infect up to 18 others. But luckily, vaccines can change that. The fraction of people who are vaccinated or immune can lower the reproduction number below 1, which means the disease is disappearing. 90% of unprotected people who come in contact with somebody who has measles, even just breathing the same air, will become infected. To control a super contagious virus like that, the vaccination rate has to be 95% or above. And right now, the US is lagging behind, and measles is making a comeback. The Guardian put together a simulation of just how this so-called herd immunity works. When enough of a population is vaccinated, even if it's not 100%, the herd can protect the unprotected. With vaccine refusal on the rise, our herd immunity is breaking down. Preventable diseases like measles and whooping cough have become our scurvy. Most of us don't know anyone with polio, and I mean, measles, it's not that bad, right? Well, yes, it is that bad. Before the age of vaccines, millions of people were killed by diseases that today are just bad memories. Vaccines have let us develop a sort of generational amnesia. Today, we expect our children to grow up healthy, and we're lucky that we don't appreciate just how dangerous these diseases are. Like science writer Seth Mnookin says, vaccines are victims of their own success. Because of stories like Andrew Wakefield's discredited study wrongly linking vaccines and autism, and the news media's obsession with pictures of crying, terrified children being poked with needles, people are nervous about vaccines. This anxiety isn't new, though. When Edward Jenner in 1798 saw that milkmaids didn't catch smallpox, he realized that because they'd been exposed to the similar cowpox disease, they were immune. And based on this, he developed an early smallpox vaccine by inoculating humans with the cow virus. In fact, the word vaccine itself has bovine origins. Still, as far back as 1802, critics were claiming that the smallpox inoculation would turn you into a cow. Vaccines don't come without risk. Nothing does. But on average, fewer than 1 in a million people will experience a dangerous reaction to common vaccines. Car accidents, playing outside, even walking will injure more children. Vaccines are asking us to do something altruistic, to make a choice to protect not only ourselves and our children, but also those around us. Author Eula Biss says that vaccines are one of the most empathetic things that we can do. A system that's based on people voluntarily using their bodies to protect other vulnerable people. That's something I hope we don't forget. Now, I'm a doctor, but I'm not that kind of doctor. It's natural to have questions about vaccines, and you should have a conversation with your medical professional. They want the best for you and yours. I will give you one prescription though, and that's to subscribe so you can get a full dose of science every week. And if you want to read some amazing books about vaccines, check out Seth Mnookin's The Panic Virus and On Immunity by Eula Biss. Links in the description. Stay curious. Today we know that citrus cure scurvy because they contain high levels of vitamins. Citrus fruits cure scurvy. Citrus fruit.
Okay, no need for bloopers.
We enjoy the outtakes, but we know that you all have access to Google, so you can go ahead and rewatch. So vaccines are developed because starting first off in the lab. So the first part you're going to say is what you call the traditional bench science and chemistry class, where you have vials and you're mixing things together to find out what's at. What they're trying to do is to isolate the virus down so that we can figure out what needs to come next. When we first figure out what is a good candidate and that this might actually kill the virus, then we're going to start looking to do next testing. Usually the first testing is going to be in animals to make sure that it's safe. When it's found to be safe in animals, it then will go through 3 phases of human trial. The first phase will be very few people, like less than 20. The next phase, they'll have a little bit more. And the third phase, they'll have a lot more. If all of those trials work well and go well, it then will go before some review boards in order to make sure and review all of the science, all of the results, and make sure that everything is up to snuff and that it's safe to be out. After that, they will be scaling up manufacturing, and ongoing throughout all of this whole process, there is a very stringent safety monitoring and review process, at which point anytime there's any negative effects have to be reported. And a lot of times the vaccine trials can be stopped if they're found to be that this is not going to work. Next slide. So a clinical trial is basically taking humans and, for lack of a better words, running an experiment on them. So this is something that is required that the person has full consent and knowledge of what's happening and that they agree to participate in this. So we do not do any trials that the humans don't know what's going on and that they don't know the risks that are involved. And there's no, force volunteers. They have to come out of their own volition. So like I said before, phase 1 is usually very small. Phase 2, we start adding more people. And then by phase 3, we have over, as many people as we can get in that we think would need to see any type of adverse event that we would want to make sure we'd be able to tell everybody. So we're always looking to say, okay, what side effects cause this? I'm sure you guys have all had to watch numerous ads or commercials where sometimes it seems like the list of side effects for the drug ads are longer than the ad itself. And a lot of those came from the clinical trial that was run. So after that, the Food and Drug Administration, or FDA, has to review all the evidence and sign off on it. And then there also, at that point, could be a phase 4, which really is continuously testing for effectiveness and safety and going forward. And I would think that Thalia and I would agree, we're both in phase 4 right now, that we are out and getting our vaccine for Moderna and Pfizer BioNTech out into the population and are continuously testing for effectiveness and safetiness. So the 2 vaccines that are out there right now are, again, Pfizer, BioNTech, and Moderna. You can see for their trials that at phase 3, which was the largest of their clinical trials, they had 44,000 and 30,000 adults as well in each of their arms. And then they also had a diverse group among ethnicity and then equally men and women. Next group. No, sorry, next slide. From here, I'm going to kick it over to you, Thalia.
Sure. So you've probably heard that the vaccines currently out are mRNA based. mRNA is messenger ribonucleic acid, which I'm sure you've all heard in a biology class somewhere. And mRNA can be described as the instructions for how to make a protein or an actual piece of the protein. So where DNA has sort of the overall plan for all of your proteins that the cells might need, it lives in the nucleus. But the machinery that makes the programs, the proteins, it's outside of the nucleus. And the mRNA is a copy of those instructions. I know, big, lots and lots of information and a little bit confusing. So as usual, we have a little video to help explain it a little better. I can open it. Oh, there it is.
So the new vaccine that's been used this week uses mRNA technology. But what is mRNA? So cells use mRNA to produce proteins. And we can think of this process as how it would be like to make a car. In the center of the cell is a nucleus, and we call that the brain of the cell, or in this analogy, we'll imagine that as head office of the car company. Now, our cells produce proteins in the factory part of our cells. And for this example, we'll imagine that is where the cars are made. So the head office needs to send the blueprints for the car from where it is to the factories. And that is how mRNA works in a cell. It's a messenger RNA, so it sends those instructions that we have in the nucleus, which are DNA of how to make the proteins, to the factory parts. And so what we do with the vaccine is we give you that messenger part, just a message from head office to the parts where we make the proteins, and it produces the proteins there. There's no change to your DNA, just the process of making the proteins. The messenger RNA lasts in the cells for a few days, and then it stops producing this protein. So the new vaccine that's been used this week uses mRNA technology.
All right. Get back in here. Ooh, sorry. So currently, as Greta said, there are 2 vaccines that have been approved by the FDA that are currently being distributed. The first is the Pfizer-BioNTech, and the second is Moderna. So they have a little bit different storage capacities. For Pfizer vaccine, it has to be kept in a super, super cold freezer. I think it's like -40 degrees is the required temperature for storage, and we call that an ultra cold chain, where it has to be transported that cold and stored that cold before use. Moderna just has to be refrigerated, so it's a little bit easier to handle. Both doses do require both vaccines, do require 2 doses. For the Pfizer vaccine, it is 3 weeks later, and for Moderna, it is 4 weeks later. So in these vaccines, since they are mRNA, they don't contain any actual live or deactivated version of COVID. As the video was saying, it's just the mRNA, which is giving your body the instructions to create the antibodies that you need to fight COVID. So it kind of tricks your body into thinking that you have COVID when you don't really. So many people wonder how the vaccine was developed so quickly. And mRNA vaccines are newer, but they're not unknown. So folks are scientists, obviously not us, are much more familiar with the technology and the science behind mRNAs. So most of the research had already been done, and that's because COVID, which is SARS-CoV-2, is very similar to other viruses such as SARS and MERS, which already had a lot of research beginning in 2003 when we started seeing outbreaks of SARS and MERS around the world. So the clinical trials for these were overlapped instead of running one at a time. So instead of it being like clinical trial 1, then clinical trial 2, and then clinical trial 3, they held them at the same time to expedite the process, given that it is a global phenomenon. And we've been seeing such a crazy loss of life and transmission across the world. So the vaccine makers were also able to begin production early so that they had enough supply, again, given that this is, COVID is something that we've been seeing around the world and not just in one location. Interestingly, the vaccines that were authorized are 95 and 94% effective. So this means that beginning 2 weeks after your first dose is given, when they were doing the clinical trials, the group that got the actual vaccine versus the group that had the placebo, just like the fake version, they virtually stopped getting sick with COVID. And by 3 months out, the vaccinated group for each vaccine had 95 and 94% fewer infections of COVID-19, which is pretty crazy. Some of the other vaccines, like for example, your flu shot, from year to year, sometimes is only 50% effective. So having this vaccine for COVID, which has just impacted our lives and our world so greatly, and being able to have them be so effective is really pretty critical. So the next thing we want to do is just demonstrate another quick showing, a simulation of how you can see the differences in a community that is vaccinated versus not. Greta, are you seeing the simulation screen? Okay. So we'll start with a scenario in which 30% of a community is vaccinated. And you'll see, you're going to see an animation shortly, and you'll see these little orange healthy dots, the red sick dots, blue recovered dots, and unfortunately the black dots of folks who are deceased. And the kind of turquoisey green color are folks who are vaccinated. So I'll start the simulation with 30% of the population
Being vaccinated.
being vaccinated. Thank you. So as you can see, of our population of 200, 60 of them were vaccinated. And because it was only 30% of the population, we still experienced 21 people in our community that died. So now we want to move up to a 70% vaccination rate, which is the goal for COVID-19 vaccinations in New Jersey. We're trying to get to 70% of adults being vaccinated. So you see in the simulation with 70%, we had fewer sick individuals, more recovered, and no one died. So that just shows how important it is to have a majority of your population vaccinated. All right, so our final poll of the day, and then we will open up for any questions or comments that you guys might have. But it's an easy one, I think. So true or false? 30% of us getting vaccinated is enough to eradicate COVID-19. All right, it looks like everyone got the answer right. The answer is false. Unfortunately, 30% is just not enough, particularly for COVID-19. It is an extremely contagious transmissible disease. So we have to have a higher rate of vaccination in our communities around the world to make sure that folks are safe and that we are able to slow the transmission. So that is all that Greta and I have for you for today, but we are totally happy to take any questions that you might have about anything we talked about.
So I see a question in the chat from Daniel about how do you find the appropriate dosage for and I'm assuming this is for vaccine. Daniel, I'm going to just bring you off of mute if you want to clarify any of your question. If you're able to unmute and just clarify that you're looking at the dosage of vaccine, correct?
Yes, that's correct. In the stage 1, it said, it determines the appropriate dosage, and I was just curious how to do that.
I don't know if Thalia knows better than I do, but we do have a lot of the scientists in the labs, and I think with the experiments in terms of like starting out first with animals and then the first trials of the humans, that they refine it and learn what the dose is from there. I think it's very interesting though, because these are the mRNA vaccines that they don't have like any kind of additives to them. It's really that messenger RNA that just lets your body recognize to build the immune system. But I unfortunately don't know that I or Thalia has the best answer to this, as we are definitely not the scientists out making vaccines. But it is a very intriguing question that I'm pretty sure I will be on Google later trying to understand. Any other questions?
Hi, Greta, it's Kim. I just I had put something in the chat about masks, and there's this question about the flu seems to be on the a decrease in terms of cases, but COVID sort of continues to rise. And there's this question about, well, if people are masking and that's having a good impact on the flu, then how is COVID still on the rise?
I think
I have so many opinions.
it's really interesting. So, and again, I think caveat, this is a bit of an opinion as well, but I think that, people are a little bit more careful, and COVID is a little bit more transmissible. We're also still learning a lot about it. So, even though folks are more familiar with the flu, because it's something that we see every season, we're still learning a lot about COVID. So I don't think that it's a lack of effectiveness with masking. There might be something that we just scientists haven't cracked the code on yet, because in all honesty, it's only been 1 year since COVID just came crashing into all of our lives. It didn't even have a name yet until last February. So I think that we still just have a little bit to learn about how it reacts, the long-term effects, how it's transmitted. We now even have, I think, 2 or 3 other variants, strains of the disease. So I think these questions are gonna take some time to figure out the answers to, and we're gonna be learning about it for years to come, I think.
I think my opinion, again, all opinion where we don't have the science behind us. I think our younger kids aren't really great hand washers, but they're very good mask wearers. And so I think, when we see our young kids who are keeping their masks on at school and such like that, and I'm talking about like the 3, 4, 5-year-old crowd, and they're probably one of the key transmitters among flu because of the poor hygiene and not wearing masks. So my theory that I need to test out here is that because our kids, the young kids, are so good at wearing their mask, that they're not passing on as much flu as they might normally do. But COVID, again, as Thalia was saying, is so transmissible, and we know some of us adults are not so great at mask wearing, that it's allowing the COVID to continue to spread, because that has really gotten a hold of the community, and we haven't been able to get our rate of COVID down so that there's not as much circulating around, whereas flu just hasn't had a chance to take off yet because we have been so good at wearing our masks. With that said, it's January. Typically the height of flu season is February. So it'll be interesting to see if our theory kind of continues to hold up, that masks have been very good against flu. And hopefully if we get COVID down, masks will become more effective as well. And I think I'll just add on that one last bit that I want to say too, is cloth masks are not 100% perfect at stopping transmission. They're good, but they're not perfect. So I think, that's one of the things to remember as well.
Good point.
So I see another question that we got is, how concerning are the different strains of COVID-19? And do you believe the current vaccines will be effective against them? Very good questions. I think the concern of the current strains of COVID-19, one of the things that I think is good is what has been known to date. Again, as we said at the beginning, our knowledge can change, is that the new variants don't seem to be any more deadly. So there's not as, more people dying, which is always one of the things that we mark and are more concerned, our concern raises. They are able to spread much quicker. And so that very much has concern. I, have a couple of news sources that come in, and when I see, there were 25,000 new cases of COVID today in Spain, I'm like, I don't know what I would do. Like when I look at New Jersey's numbers, we've been hanging around the 5,000-6,000 mark per day. And when I think about having an increase, it just, it's concerning to know what that would mean. Would more people need to go into the health care system? Are there open beds? Is there going to be no more ventilators? In terms of the current vaccine effectiveness against them, I don't think we have enough evidence there yet to really know. I think we're still learning since we've only really had vaccines for about a month. So I think time will tell, but I am hopeful that our current vaccines are working as well. Thalia, do you have any other insights on that, or?
No, I think you're right. It's going to be, we're not used to this. We're used to, as humans, having a lot more information and historical knowledge and background on things. So for this to be playing out in our lifetime, it's a little unsettling for a lot of people, ourselves included, because usually, as public health professionals, we have time to figure things out and test out hypotheses and give the public more confident responses to answers. And we and neither a lot of scientists are just not able to do that because we are learning about it as we go along. So I know, I would encourage folks to be patient and continue keeping up with updates from reliable sources, your CDC, the World Health Organization, FDA, because it seems a little crazy because usually the CDC puts one thing out and that's it. But the number of updates that we've had to make, that we've seen the CDC make in the last year, it's just kind of unprecedented. So I think it's definitely, like Greta said, going to be something that's going to come along with additional research and testing, and we'll see. Oh, I do see another question. Oh, speaking of the World Health Organization, how do you think the decision to rejoin the World Health Organization will impact relief efforts in America? So I think being a member of WHO is important because it gives us an opportunity to be on the same front with our global partners. And for there to be a governing body sort of coalescing and bringing together different research and information, and the fact that we are having some of the worst COVID, we've got the highest number of cases and I think the highest number of deaths in the entire world in the United States. I think that we will benefit from research happening in other countries and the sharing of information about the different variants and those things. Being able to collaborate and coordinate efforts for vaccine development, for sharing of information, and there are new symptoms that may arise and things of that nature. I think that's really important for a novel virus like this that we haven't seen before and that has taken our entire globe by storm. So I do think that there will be positive efforts that come out of this and allow us to, not just as a nation, but as a world, learn, grow, advance, and be able to help each other out and protect ourselves a little bit better. Greta, any additional thoughts?
I think I had the same thought as you, is that the ability to learn from our global partners is so critical, and that there's a lot of great science going on out there. And so I really, think that it's very important for our scientists that they do have this community to talk to and be able to have the best insights. And, there might be something out there we don't yet know. And if it can get us back to what we affectionately remember as normal, I'm all for it. So I
Yeah.
just wanted to, if there's no further questions, just take a moment to thank you for attending, and thank you to the organizers for asking us to be here. You know, we are public health geeks on our good days, and this stuff really is very, very much our heart and soul, and the opportunity to share with you all our public health geekiness. We just really appreciate all of your time and attention, and hope that you have learned a little bit more about public health and how cool of a career path that Thalia and I stumbled upon that has really been a great day, been a great challenge along the way.
Definitely, I echo that. If you guys have any questions afterwards, anybody's looking for an internship or any type of experience like that, please don't hesitate to reach out to Greta or I. Greta is an epidemiologist by training. In my end of the public health world, it's more policy related and primary care. So we're at very different spectrums of the very different ends of the public health spectrum, but still working together to do some really important work. And it's not every day that you get to see some work that you start doing actually out in the world, like the very next day. So COVID has definitely been a roller coaster ride, a major challenge, but not only have, I think, we learned, but it's really great that we've been able to help our communities as well. So hope that you guys learned something today. And again, if you have any questions later on, please don't hesitate to reach out. We're happy to talk to you guys.
Thalia, Greta, thank you both so much. This was so informative. I know our attendees learned an awful lot. We also recorded it and we'll share it out with everyone in case you want to go back and reference it. And I will definitely be reaching out about internship opportunities and sharing those with our Governor STEM Scholars. So really appreciate that call out. For all of our attendees, expect an email with a survey. It'd be really helpful if you could fill that out. It helps us design our future programming for all of the Research and Development Council programs, whether it's the STEM Pathways Network and the Governor STEM Scholars. So really, really important data there. Again, thank you so much, and I hope everyone has a great evening.
Bye, everyone.